Assalamu alaikum everyone. On behalf of Mubahith, I warmly welcome you all to today's session on digital fronts in healthcare. We are privileged to have with us Dr. Aamir Vaince, a distinguished General and Laparoscopic Surgeon with impressive academic credentials and extensive experience in both local and international healthcare settings. Alongside his clinical excellence, his interest in leadership and non-technical skills add a valuable dimension to his work. Dr. Amir is deeply committed to mentoring and fostering an environment of learning and meaningful dialogues. We are truly looking forward to gaining valuable insights from his experience today. So without further delay, let's welcome Dr. Aamir Hussain Vaince. Over to you.
Thank you very much,
Dr.
Dr. Ikra. Thank you very much, Mubahis and everybody for having me. I would share my screen now. Can you see my screen, please?
जी बिल्कुल देख सकते हैं, नजर आ रही है।
So as we all have witnessed that this digitalization has gone across all the venues, and it was around, I think, 5-6 years ago, once I was reading a book in which the author was having a balanced view that whether we would go for AI or we would not go for AI, whether it would be harmful for the mankind, and what dire consequences it can lead to. But in the end, his views were that wherever the money goes, rest of the things follows. So now we see that AI is more of a present part and parcel of our present environment, as well as uh, different frontiers. It is scoping it. There is not even a single thing that it's not touching. Even in the recent Iran-US war, we saw that US did their planning with one of the AI platforms, which integrated data from across from 170 platforms, and made the decision making process easier for the US decision makers. So coming over to the digitalization of the health, everything that we do, it has changed in the recent past, starting from our grocery or the way we eat out, and everything. Uh, so the healthcare is also following, and this digital healthcare frontier, it has come up, and in this broad space of digital healthcare, that involves digitalization of the human beings, digital data collection, and uh, you know digital twinning of the individuals, that lead to that enables the clinicians to evaluate the effect of the drugs, as well as run the surgical procedures in virtual environment in order to see the effects. Today we will be restricting our talk only to the digital front door. The front door, that whenever you approach any house, any place, how you get the feeling of the front door. So with this introduction, I would like you all to quickly respond that whenever you approach a healthcare facility, either digitally or in physical sense, what are the barriers that you see? Which barriers that you assume is the biggest impediment that causes friction during the journey of the patient? So you all can scan the QR code and then Can you see this QR code?
Yes, we can.
Yeah, please scan the QR code and then you can answer, please. So one of the point of friction is patient access, that the way the patient comes to hospital or finds the way it approaches the healthcare facility via digital channels. Uh, Operations in isolation, that is, data is in silo, or the departments, they are not in synchronization if you talk about the physical, environment. And then long talked about the clinical load, workload. Is it the impediment, or there are some equity barriers? Since there is, all humans, though they are equal, but they are not equal in socio-economic or other, factors. So their needs are different. So they are equal, but their needs are different. So that's why the equity barriers, they come up. So you have been able to scan the code?
Uh, I'm there, but I cannot access it. I don't know, so I may have to log in with this some other email.
Okay. What about the rest?
It says to log in with an institutional ID, not the personal ID.
Yeah. So maybe we can answer
Okay.
in the chat box.
Okay. Okay. So we will
ABCD,
discuss
yes.
it later. So, eh, there can be, it's basically a poll. So generally, we all can have our own experiences, and we all have our own opinions. But generally, the clinical load, it's deemed to be the biggest, impediment. And that comes to the how we architecture this digital front door. It has to be, in architectured in such a fashion that it gives a seamless experience starting from the entry of the patient with the digital platforms like the applications, like we all have experience of Sehti in KSA. Uh, then uh, leading to the next step is this tri-engine that is leading to agentic AIs that is integrating in every sort of information into one place, and then it leads to frictionless uh, workflow that leads to frictionless outcome and at the point of the care for the patient. So now, uh, this is basically a comparison the way AI is evolving. The traditional workflow, it was, haphazard. The way even the AI or the even digitalized system used to work, it was haphazard, and there used to be a lot of friction. And there, what we call in surgery, there was not economy of the moment. So in surgery, it's very important that you learn how to be economical once you are moving your hands, or any sort of movement that you are making during the surgical procedure. That should have an effect. If it is all in vain, then you are wasting your energy. So that used to happen. The waiting time were long. In most, we are talking about the part of the world where there is appointment-based system. Uh, we in our part of the planet, there are generally patients are accepted as walk-in. Whenever they come, they are served. And in those appointments, there was around 30% no-show rates. That means that every third patient that was scheduled for appointment would not come. So that lead to a wastage of lot of resources in terms of energy and as well as financial resources. With these embedded agentic AI that is capable of regulating the workflow and managing the electronic health records, that was taking a heavy toll on the clinicians. Uh, in some studies, around 5 hours out of 8 hours, the clinicians they were spending in just these clinical role, their clinical jobs, which were basically uh, sort of non-clinical, and they were extra burden on the clinicians, and that lead to medical errors and problems and poor outcomes. And especially one here I would like to talk about the clinical burnout rates. So burnouts in clinicians, it's very high, astonishingly high, around 41 to 52% of the healthcare workers. They are experiencing this form of burnout, that is depleted energy, depleted emotionally. As we know that most of the clinicians or residents, once they are going through the residency, they are basically on the edge, and there are high chances of the burnout. So this agentic AI that would uh, regulate the flow of the patient throughout the hospital, that would lead to less burnout, and that would give the clinicians their capacity back, and they can use the energy and other valuable time for decision making that is of value for the patient. If we dissect the digital front door, it's basically uh, a three-layered structure. On the surface is the patient interface, the how the patient would come and interact with the hospital. It can be through the mobile, it can be through some computer-based device, or it can be through some digital chaos machines which can deliver the information to the patient, from the patient to the hospital. And then in the hospital, that information that comes in form of patient information, then there are certain standalone systems in the digital facade that can basically check the vitals, which can they can assist the patient in taking history, and then all that data the, that comes in the brain of the hospital, that is the agentic AI, and that would orchestrate all the data, and then that would uh, schedule appointment, do triage. If the AI finds that the symptoms are grave and the patient needs immediate attention, it can even activate emergency care services. It can call for ambulance, request ambulance, and things like that through the secure messaging channels. And it can also do smart scheduling of the appointments for the patients, so that clinicians do not have to worry about that. And all these two tiers, they rest on a solid foundation, and that is uh, basically the system in which, that is the interface in which this both of these patient-based and hospital-based uh, platforms, they can talk. So this they the and there is also regulations that govern these systems. So these are the basically foundations that need to be taken on into account. And this fast healthcare interoperability resources, this is FHIR, and application programming interface, APIs. Basically, FHIR is a application programming interface that leads to interaction between these two upper pillars. And as we dissect through this evolution process, we have seen that the AI and digital transformation has grown massively, especially after the COVID era. After the pandemic, there has been development of the channels which were omni-channel, the wearable and self-caring, and the other platforms that can lead to clinical grade data. If we talk about phase one during somewhere around 2010, there were fitness trackers, step counters, but they were operating in isolation, and the data was not clinical grade, and it was not integrated into the clinical settings. Coming over to the pandemic, there was forced adoption and rapid deployment of standalone telehealth, digital check-ins, but it was also very fragmented. And then the world saw that the things can get disrupted during the COVID, and then they started about thinking uh, of doing more in digital health. And then these omnicare channels, platforms, they came up, and but they were also source of excessive fatigue for the clinicians. With all these digitalization, the person bearing the biggest burden was the clinicians. And now with the newer agentic AI, orchestration, it's thought that a lot of weight will be taken away from the shoulders of the clinicians, and many processes will be automated, and clinicians will also only step in where there would be high stakes environment. So this is what I was already saying, that if we talk about the decision making, we will leave the complex decisions to the healthcare makers, healthcare workers, and only decision making of transactional nature, that will be done by AI. It would help the clinicians in scheduling the appointments, digital check-in, assessing test results, or making discharges, doing documentation work. So it would basically decrease the workload of the clinicians. Whereas high stakes uh, environment and high stakes situations would definitely be left to the clinicians, and it would AI can suggest, but we would not. That would not be the final decision maker. Even in these issues of transactional behavior, scheduling of appointment, if some clinician sees that like if some AI agent is giving appointment uh, that is delayed to somebody who is having serious symptoms, then that clinician or that person signing off will override the decision of the artificial intelligence agent, and uh, they would schedule an early appointment. So this is again the same engine. We have this stimulus that comes in the form of somebody approaching for healthcare, uh, patients or people coming for routine checkup. So they may have different needs. They can schedule online appointment, and this all this needs to be graded, that how easily the user was able to assess the system. And then this hospital image, it depends upon this uh, the ease of the access, the door, once you are welcomed at the door, and then you get into the system, you will have a different feeling. And generally, what they say is that people will forget that what did you do, but they will not forget that how did you make them feel. If you make them feel good about the system in the beginning, what we call as first impression as the last impression, as we have already discussed, then the the patient is likely to carry good impression about the hospital, and it would be, you know, a frictionless digital experience. And then they will be a sort of collaborating with the hospital uh, to improve the services. They would more likely to share the information, and they would be trying to be more helpful and transparent, and this dart analysis that would lead to better outcomes. So another this same continuation of burnout and reclaiming of clinical capacity. Once all these tasks, which are not petty, but they take a considerable amount of your valuable time, if they are taken off your shoulder, then everybody, uh, all the healthcare professionals, they would have more productive time with the patient, and it's sort of they would reclaim the capacity. And this digital front door that we call, it's not only the door, it's a sort of a well synchronized process that goes deep up till the patient is discharged from the hospital, and even beyond, the care continues in the community. So there is this, earlier we said that the no-show rate was around 30%. So with agentic AI implementation, there is 15% reduction in no-shows. And there is 20 to 25% reduction in delay of the care. The care is not delayed once, uh, if there is information, like if we have 10 hospitals in Lahore, and the nearest hospital to the patient house is having a busy OR, and the patient needs emergency surgery, the patient can always be directed, if there is a good horizontal and vertical integration, of course, with secure platforms without any risk of breach of the data, then the patient can be transferred to the nearest hospital, and the care will not be delayed, instead of waiting for uh, culmination of that surgery and then getting the patient cured. So basically, this all has these three components. There are certain, if we talk about this area, there can be many sources of the data coming on into this, hospital brain, that leads to this structured clinical workflow. And it's basically an ecosystem. In this ecosystem, in which there is fast healthcare, interoperable, uh, you know, uh, computing of healthcare data. Uh, there is exchange of data across all primary, secondary, and social care setups, and that leads to a seamless care. And so they need to be, whenever something new is coming, we need to have legislation for everything that is coming up new, uh, because there are people who are prone to take advantage of those newer situations. So there are different legislations in US and Europe. In Europe, they give more autonomy of data handling to the patient, whereas the US gives a bit more leniency to the hospitals. Uh, in Europe, even the patient can request uh, to, there is one thing they call right to be forgotten, to completely erase the data, whereas this is not possible in the settings of USA. So this brings us to another poll. We'll see if you can see the.
I think if people cannot respond, they can just send the answer in the text box, in the chat box.
Okay, that would be fine. So we would try if we can. So basically, what do we think that who is the most responsible person to influence digital strategy in our unit, in your unit? Either it's chief medical information officer, a chief health information officer, chief nursing information officer, or the hospital board, or our IT department, or is it unified governance?
So everybody who's here, that you can answer with A, B, C, D, or E, whatever option you think is the right option. Just type that and send in the chat box.
Yeah, basically, it's everybody has their own experiences. There are no rights or there are no wrongs, but it's basically, uh, you know, we are here to learn from uh, each other's experience. So something that is right here maybe uh, not that appropriate somewhere else. Uh, but most of the consensus is about this unified governance. So unified governance is needed once we take this issue of digital health strategy and artificial intelligence.
We have
And
two answers and both for unified governance.
yeah, now we have to be, once we are taking into account this, uh, once we are embracing this digital health front door, we need to take care that we are not leaving anybody behind. Because I was going through a case report of 1960s in United States of Truman Medical Center, and the board of governor of that hospital, Dr. Truman, he identified that there were various communities uh, in which were not having same access to the healthcare. Everybody was not being treated equally. There were a lot of variations, rather uh, discrimination, the way the urban and rural people were being treated, or the people of color and other people were being treated. So now, Alhamdulillah, we have this better concepts of equity, and once we are trying to embrace anything, we need to plan, acquire, or implement and monitor all of these technologies in a way that everybody is catered for. And in US, this May 11 is the deadline in which they have they require that all digital health interfaces should be fully compliant with people who require special assistance, and they should be accessible to everybody. And once we are talking about communities in Pakistan, having served in Africa and in Pakistan in remote areas, uh, it's not that these technologies they are for just for the they are some sophisticated tech gadgets that only patients with affordability should have. All the communities they need to be catered for, like this uh, concept of digital health, this one concept that is the telehealth, that can be uh, very much adaptable to our far furlong areas. Uh, the people they can have wearable, or they can have medical grade devices or with sensors that would lead to that can tell them that these are the uh, warning signs, and they can relay the data to nearest clinical facility, and the doctors over there they can respond. And we all know that there are areas, uh, especially in the mountainous part of our country, where uh, the roads are blocked and the weather is very harsh, and the people find difficult to have access. So these standalone kiosk machines, they can be a good solution, or uh, medical sensor devices that can help the patients, like uh, continuous blood glucose monitoring devices, or other wearable devices. They can be utilized, and so that everybody is catered for and nobody is left behind. Coming over to the economic aspect, and that's, I think, the second last or last slide. So that's normally said that if you want to see that where an in, where the intent of some person or some organization or some country is going, you have to see where the money is going. And this digital front door market, it's around, it's likely to surpass $82 billion by 2031. And it's said to have increase in revenue costs by 50%, and the cost reduction is around by the same figure, around 50%, 47% cost reduction. And there is another thing that we call ROI. Our finance guys, they are very fond of this, and especially in the real estates and investments, this term is uh, frequently coming up, that what is the ROI. And there are very few things in which you would find such a high ROI, like 450% in this case. So this is again this flywheel of agentic health, that patient comes, there is seamless entry, then all the patient is treated in a frictionless manner, and that builds confidence through consistent, reliable interactions and transparent communication, and that leads to trust. And once somebody is trusting you, then there will be high yield data, and there would be transparency, and once that data is collected, that can be fed to the smart AI agents, and then they can devise a very smooth workflow, and that workflow would lead to reduced clinician burnout and cognitive load, and that would increase the clinical capacity, and the cycle would go on. And at the center of this is a very powerful message that we have already discussed, that digital front door is not just some static entry or some static entity. It's a continuous process that is self-optimizing, and it operates in the form of an ecosystem. And to conclude, I would say that, I'm sorry for this. To conclude, I would say this, that we have to make this technology invisible and the care should be visible. The care should be so visible that everyone that is coming to the healthcare setup goes satisfied and with a best possible outcome. As healthcare professionals, that's our primary goal. So that's it. Thank you very much. Now, if we can discuss something, if there are some questions
Yes, thank you, Dr.
or
Amir. Please,
comments.
if you could just turn on the last slide that you were showing us. Yeah, this is a beautiful message, a very beautiful message. The ultimate goal of Digital Front Door in 2026 is not to force patients to interact with more technology. The goal is to build an infrastructure so flawless, seamless, and intelligent that the technology effectively disappears. This is a beautiful message.
Yeah, that's it. It's not that we are asking people to, embrace technology forcefully, because nowadays the things are coming up very quickly, and initially uh, what they say is that AI is the one technology that has reached millions of users in no time. Previous technologies, they used to take decades.
Yeah,
But it needs to be invisible, and it needs to be caring. Instead, the patient should not be worried about that. M- Having worrying for learning newer technologies, and it should be very user friendly. And they say that if it's taking more than 2 or 3 clicks, then it needs to be revised.
yeah,
And we all know that once we are, maintaining electronic health records of the patient, there are plenty of clicks.
of course. Okay, you this is a very beautiful presentation. I just wanted to ask, you recently had your degree from Royal College of Surgeons of Ireland about leadership. How much are they teaching this digital health front in in leadership, in surgical leadership?
Generally, they have short courses, and they also have this diploma, postgraduate diploma, uh, courses as well. And they are also offering MS in multiple subjects, and leadership is one of that. And though they touch digital health in that, in one of the modules, they are touching digital health and managing change. That is this, this whole arena of the healthcare is changing. But
Mm.
they have a separate course on digital health for
But
all
they do
those
have
who
a
are
module in
interested.
this leadership degree that you just did.
Pardon?
They do have a module on this digital health.
Yeah, it's part of one module.
Mm.
They have a module on managing resources in which they touch upon this digital health, and then there is a module on managing change, and they touch upon digital healthcare there as well. Uh, but they have a separate course. If somebody is interested, there is a separate course of around 10 to 12 months, and even they are offering masters in digital healthcare also.
Okay, after seeing the systems in KSA and Ireland and UK, What do you think? How long will it take for Pakistan to develop the system? Or should we have any hope or no?
So the thing is that nowadays what we call there is minimalist approach that small is more. So it's not that this we have to deny our population with these advancements. Uh, our people they have lot of smartphones, more than I think 120 or 130 million people out of our 250 or 260 million population, and more than our 50% of our population is having smartphones. So there can be cheaper solutions. Like we do not need to build, THAAD or Patriot that costs one missile $2-3 million, or so we just need a Shaheed drone. So that's
That
much
is very
cheaper,
political
and
of
that
you to
would do
say.
the
That
job.
is very political of you to say.
Yeah.
Okay, if there's any other question, people, you can ask the question in the chat box or you can ask directly. In the meantime, I'll ask another question. Do you think uh, it will take, decades, maybe, 25 years for the government to develop the system in Pakistan? So should we go for uh, a hospital level automation system?
Yes, that's very right, sir. Uh, this system of digital, appointments and digital, what we call digital front door, it's operational in some of our setups in the private, like in Shafa International. We have this, you can book your appointment. Similarly for in Aga Khan, and in most many of the hospitals, they have built their own apps, like Shalimar Hospital in Lahore. So they do have this system in which you can schedule your appointment, you can see your results, the labs they have their results, and they also sort of give a brief interpretation of the lab results, even that this is it, and they also give a sort of short recommendation even. Uh, but our main worry is public sector. In public sector, we do need a lot of things to do, and in initially, as we see that we need to do, as we are talking about this different systems in KSA, Ireland, and UK, what they are doing is that they are also keeping uh, papers. So it's basically a hybrid system in which you're also doing, if the system is down, then you can, continue with the care. The care should not stop. You have papers as a background. And there is another thing that they call a black box of decision making, that at times this AI that is coming up for, Rizwan is there. Maybe he can comment better. He is working in US uh, as a decision support to the clinicians. So this at times the AI does not have any reason, but it's giving you some assessment and offering you some solution. So it's basically what they call human in the loop, that has to override, either see that whether this is a valuable insight or valuable solution that AI is offering, or otherwise it can just override. And at times they call this kill matrix. There are certain, once we are talking about governance, there are certain things called safety grills. So at times, if AI is not behaving in the best possible manner, and is coming up with uh, something that is not fruitful, then even that kill switch can be activated in the hospitals. So This is
Okay.
it, but we can have, coming over to the previous part, we can have our cheaper solutions in Pakistan,
Mm. Mm.
especially in public sector.
Okay. So now you made a political comment, and that this has reminded me of one thing. We might have to go to the basics because the direction in which the world is moving, we might have to go to the basics. We might not have energy. We might not have electricity in the future because, one Strait of Hormuz is closed and price is gone, haywire. And in that case, would AI be helpful to us, or we have to keep a hybrid system?
Yeah, that's a very wonderful comment, sir. And especially, unfortunately, whenever humans learn something new, first thing they implement is they find utility in is destruction or overpowering other humans. So this is what is coming up. We saw this in the previous century in First World War and then in Second World War, and this is the situation that we have now is similar to the Third World War. It's I think it's almost there, and anything can happen if the ladder of escalation keeps on going up. Then there would be serious deficits of energy. There would be serious troubles, as far as oil, electricity, and these daily, and these daily things that we use with energy, they would come to a halt unless we develop something like solar systems. But that's not, possible in a very short point of time. That we cannot erect a whole, solar grid of to 2 gigabytes or like that to in a day. So that would take time. So it's uh,
Yeah,
we pray that peace returns. Otherwise, I think the humanity is going in a backward direction here.
that's true. That's true. So, I think it was a wonderful presentation. I've learned a lot from this. If anybody else has a question, please ask, or any comment to make, you're more than welcome. I think Wasif was here, and I could also see Shafaqat. Wasif could make, a political comment also. We can learn from him. No, I do not. Sarvas is here. Welcome, everybody. Sajamid is also here. So, I think that's the end of it. It was a beautiful presentation, a very well presented, very well prepared lecture. And I just love the slides, how you make them. I don't know, but I will ask you how to make these slides. So I will ask
Inshallah,
you in
inshallah.
in in, in private messages. So thank you, Dr. Amir. Thank you so much for this lovely presentation, and we hope to see you more on this platform. We again welcome you,
Inshallah.
and we thank you for being here and giving us this wonderful talk.
Thank you very much, sir. Thank you. Player is all mine, and thank you, everyone.